Welcome to KMET 1490 AM ABC News Radio and the Southern California Business Report with Yvette Walker, a show dedicated to highlighting successful Southern California businesses and the people behind them.
Welcome and thank you for joining the Southern California Business Report on ABC News and Talks, KMET 1490 AM, 98.1 FM, and KMET TV. I'm Yvette Walker, live, blasting our signal from the center of Southern California, serving a population of over 25 million. Get us crystal clear and on demand by downloading the free live streaming apps on Google Play or the Apple App Store. As always, a huge shout out to the team, Mitch, Bill, and Sean. I love you guys. And to our special advisory committee, visit scbrtalk.com for the full list of distinguished advisory committee members. Today, everybody, I have the distinct honor to introduce John T. Chapman. He is the President and Chief Executive Officer and CEO at San Antonio Regional Hospital in Upland, California. Mr. Chapman joined the hospital as Chief Operating Officer in 2018 and is currently the 7th President and CEO in the history of the hospital. San Antonio Regional Hospital has 363 beds, a staff of over 600 physicians, 2,400 employees, and 500 volunteers. The hospital offers advanced patient care throughout the Inland Empire. John is a clinical microbiologist by training and has served as an experienced hospital executive for over a decade. Prior to arriving at San Antonio, he served as Chief Operations Administrative Officer at Highland Hospital in Oakland, California. John was not only in charge of operating at this 169-bed general acute care hospital, but also led the clinical and support services for the Alameda Health System. Some of his accomplishments included Alameda's accreditation as a Level 1 trauma center, a baby-friendly designation, and the construction of a 9-story patient tower. Prior to joining the Alameda Health System, John served as Executive Director of Clinical Services, Director of Laboratory Services, and held other positions at the University of California, San Francisco Medical Center. In these roles, among other things, he served as the director of the medical center's service lines, including its Orthopedic Institute and Heart and Vascular Institute. He also led a variety of strategic planning processes and system-wide operational initiatives. John, his wife Arnon, and daughter Nicole are avid dog lovers and enjoy whitewater rafting. John's hobbies include reading, playing and watching most sports, renovating old houses and cars, and in fact, John built a home in Northern California. Thank you so much for being with us today, Mr. Chapman.
Thanks, Yvette. It's nice being here.
Beautiful. So as you know, all of our guests share a little bit about their background and their journey to becoming the CEO they are today. And as we know, not all career pathways are linear, and that's something that I really enjoy sharing with our audience.
Yeah, you covered a lot of my background already. You're dating me there. So just a little bit about myself. I was one of those pre-med majors coming out of UC Berkeley, wondering what am I going to do with my microbiology degree, knowing by my senior year, I'm like, no, I don't want to do med school. So ended up getting into clinical laboratories. I was a clinical microbiologist at UCSF, like you said, and they invested in me. And I think that's going to be a good thing that we should talk about, hospitals investing in their community. They took care of my MBA and helped me grow into the administrator that I am today.
That's wonderful. Thank you so much for sharing that. So I think one of the first questions on everybody's mind, and I'm sure everyone's happy to hear the end of COVID, but please, Mr. Chapman, give us an overview of what COVID looks like today at San Antonio Regional Hospital.
Yeah, I'll just take you back a few years. When I first became CEO, COVID broke out, and I'm a microbiologist. I'm like, oh, this is bad luck for me. But it's good luck for the community today. And the reason I say that is I think we've reached that point in time where most people have been either exposed to the virus itself or have gained immunity through the multiple vaccination programs we've had. So what COVID looks like today in our hospital is we still have 10 or 12 patients who come in, are identified as being COVID positive. But the more important fact is that's not why they're here. That's not their primary diagnosis. They're coming in with congestive heart failure, pneumonia unrelated to viral pneumonia, uncontrolled diabetes. These things, so COVID is more of a secondary diagnosis, not really impacting the patient's care, not really impacting the level of care they need. No longer are the days where we're seeing 250 people at ICU level expiring because of the virus itself. And for you history buffs out there, if you look at the 1917 to 19 influenza outbreak, that's exactly what happened. We gained I'm sure you've heard the term herd immunity. So knock on wood, that's the hope. There's always the possibility that some crazy strain comes out and that's not recognized by your immune system, and we're in this again. But after 2 years and probably 36 strains that I'm not going to recite back to you, we're doing good. In fact, on April 3rd, the California Department of Public Health followed CDC's Center of Disease Control's guidelines, and masking is no longer required even in hospitals. So good news on that front, Yvette.
Beautiful. So in addition to the fact that you started just before COVID, I would say that was a tremendous blessing to the region and to our hospital, because my understanding is that the hospital was able to realize, 30% below the national average in deaths related to COVID. And I'm wondering how much of that has to do with your microbiology background.
Oh God, don't say I saved everybody. It was the physicians and staff and providers here. But it did prepare us better.
Right.
We were actually one of the first hospitals in all of LA who were testing every patient being admitted for COVID. And as you know, there were many asymptomatic patients that either was early in their infection and that went to clinical pneumonia, or they could have passed it to staff members or other visitors or patients in the hospital. So we are proud that we were one of the first ones who tested and isolated these patients. Secondly, being an independent hospital, and that's something we can talk about today too. We do have an advantage. People think you're not a system, you're not part of Providence or Kaiser or Sutter. With an independent hospital, at times that can be good, right? There's checks and balances. There's check marks and minuses for not being part of a large system. With dealing with a COVID pandemic, it definitely was a big, huge plus. We were able to be nimble and change how we took care of patients based on literature that was coming out hours apart, right? Where our clinicians actually put those learnings into how we were treating patients. And I think that was the primary reason why our, what you've referred to, our mortality rate dealing with COVID patients was 30% lower than both the state and national averages. So we did well for our community.
That is remarkable. And I'm so happy that you were able to realize that. Again, such a blessing for our region. So as we look into the future, I understand the hospital develops and works on, strategic plans that look out 3 to 5 years. Can you talk a little bit about what that looks like and what those main efforts are that you're going to be focusing on?
Sure. Just for your audience, a strategic plan typically is the crystal ball. Where is your organization going, at least for healthcare, going to lead your community in the next 3 to 5 years? A lot of that has to be based on data, right? And one of the key data elements for a community is called the Community Health Needs Assessment, CHNA. That's typically required of a community to be done every 2 years. And it really breaks down what are the morbidities, mortalities, the risk factors for the community by zip code in your region. We had just completed ours about 6 months ago in collaboration with our Medi-Cal managed care organization, the community that you know as the Inland Empire Health Plan. And it sheds light on exactly if, as a hospital, we're supposed to be putting the patient first. It helps us to determine where and what for each patient population. So as an example, Ontario, one of the largest communities that had COVID admissions in our hospital was in Ontario. They have a very large Latinx community, which carried risk factors, some of them high blood pressure, obesity, sociocultural, families living in close in cohorts, right? And that led to them being really hit hard in that community. So no longer is the idea of one size fits all on how a hospital takes care of their community. It really has to be a plan for each community. And that's where you get into equity and inclusion efforts, right? So our 3 to 5 year plan is based on that type of data. So as an example of one of our strategies in the next 3 to 5 years, aging is actually considered inequitable, meaning that we're going to have a huge number of community members hitting the Medicare age, right? 65 to 70 and above. Who are the most people who are getting sick and in hospitals are those of that age population, those who are in a skilled nursing facility, those living in assisted living, perhaps those living with an extended family like we talked in Ontario. So how are we going to make an impact on them? And sharing with you, we just purchased the Mercury Insurance building in Rancho Cucamonga. It's a beautiful 165,000 square foot building. And we're making that a center of aging. So what does that mean to a community? I'm sure your listeners have a mom, dad, grandma, grandpa out there who hard to get around. What kind of providers do they need to see? Probably multiple in a week or a month period. My own mom, 86 years old, primary care, multiple specialists, has to go to the pharmacy, needs to get durable medical equipment, has to pick up her prescriptions, but she's wheelchair bound, has dentistry needs. What type of dentist is outfitted with someone who can't get out of a wheelchair? Hearing aids go out. Where are you going to get your hearing aids? So I don't know about your listeners, but if they're like me, you're running around for hours trying to just take care and navigate healthcare for the senior population. This Center of Aging will have all that included, a one-stop shop.
Wow.
Including PT, OT, imaging, lab, as I said, audiology, geriatrics. We're really excited what this means for our community. And so are our payers and insurers who are in the Medicare managed care market. Like Optum. Optum is a huge Medicare managed care. They're partnering with us. They said, we want in on this because this makes sense.
Right.
So yeah, we're excited, as you can tell.
Absolutely. And I think you mentioned you would even offer tax services, right? We're in tax season, so I had to throw that in as well.
Yeah, seriously. I mean, how many seniors, if they're like my mom, they're stubborn, I'm going to do it myself, but they need help. So if they're not going to listen to their son, they'll listen to a tax accountant who may be next door to their geriatrician. So the idea is to provide that type of augmentation as well.
Beautiful. Well, I'm so excited. And when are you looking to open this Center for Aging, this new building, this new property that you recently purchased?
Well, if you think of all the initiatives I just mentioned, it will have to be in phases, right? So the first phase is to get the clinicians in there. And there are a number of clinicians in the area who are salivating to be part of this effort. You think of the specialists who cater to seniors, neurologists, right? Orthopedics. God knows how many knee and hip replacements there are out there in our senior community. Dentistry, geriatric primary care. So occupational therapy. Your mom or dad may have a risk for falls. An occupational therapist teaches them how to get around a kitchen, a house, how to navigate. They actually come out to the homes for those individuals who do want to stay independent. So yeah, those are good examples of what we're going to target first. I'd say we'll have all the services that I just mentioned up and running within 36 months.
Wow. That is remarkable, but it's going to be absolutely transformative for, for those that are in the aging population and those that are caring for them in the aging population, such as yourself and, others that are caring for their parents or loved ones. But as you mentioned, have a challenge spending hours upon hours getting their loved ones from appointment to appointment, from one side of town to the next, right? So having it all in a seamless, streamlined fashion where you basically probably have to go maybe up one story, down the hall, and make it a one-stop shop for the aging person and for the caregiver. It's just, I can't even imagine how much time and effort that's going to save, and really the quality of life and how that's going to enhance the quality of life for everyone involved. That's a tremendous gift, another gift to the region. So thank you for that. As we know, the healthcare field is a tough space to stay in the black, right? And a majority of hospitals are losing money. What is happening with San Antonio Regional Hospital today in that front?
We've actually stayed profitable over the last 5 years. We're very proud of that. A lot of that has to do not necessarily with good payer contracts, but what I look at as clinical and operational efficiencies. I'm lean certified. My background is metrics. You can't manage what you don't measure. We want to be able to provide high quality, but in an efficient means. And I think over the last 5 years, we've been one of the few organizations who've been able to do that. Stay lean, get our quality improved. For instance, on the Medicare STAR report for both San Bernardino and Riverside County, who has the highest score? San Antonio Regional Hospital does. And we're talking about Pomona as a competitor. We're talking about Loma Linda as a competitor.
Wow.
Kaiser as a competitor. We're very proud of our standing with quality. Because someone may point out, if you're being efficient in terms of labor, etc., does that mean poor quality?
Right.
Right. As long as you put the patient first and build those efficiencies around the patient, you're going to have great outcomes.
Absolutely. And I've been very fortunate to be able to receive care at San Antonio Regional Hospital, as well as my children. And every time that I've been there, it's exceptionally clean, well-staffed, organized. I mean, just beautiful, welcoming, and warm, right? And that's a very tough thing to be able to create, but it happens every day at San Antonio Regional Hospital. And there is nothing that, I think, at least personally, that I can point to and say, gosh, they should focus on this or they need to work on that, because it seems like not only are you covering all the bases, but you are, looking forward, such as, with your Center for Aging, to find new ways to serve the community. And that's just exceptional and very inspiring. So thank you for that, Mr. Chapman.
Well, Yvette, I could actually point out something that does need improvement.
Oh, let's
talk about the reasons for it. Anybody going to any hospital's emergency room these days, bring a book. There are excessive waits. Our average turnaround time from a patient being seen in being registered to being seen by a provider and out the door ranges anywhere from 3 to 4 hours. We'd love for it to be less. You can imagine during high impact days, especially during COVID, oh my God, it could be 8 to 10 hours.
Right.
And part of that has to deal with some of the items that we have to tackle in the community. Behavioral health, which I know we'll talk about eventually, is impacting hospital emergency rooms. We're seeing up to 7 to 10 patients who are taking up beds in the emergency room who shouldn't be going to a hospital emergency room. They should be going to a behavioral psychiatric acute care facility in a county if they were available. And that's something, there's a hint of something that needs to take place.
Right.
The other component is the back end of a hospital. The back end of a hospital, typically 60 to 70% of the population who's being discharged, especially when they're higher in age, Typically, you have to go to a skilled nursing facility or acute rehab, or require durable medical equipment, which requires transport either home or to these facilities. Do you know what the actual wait is from when a patient like that gets a discharge order to being released from the hospital? An additional 3 to 4 days.
Wow.
So, San Antonio as an example, 40 patients a day are taking up one of our 363 beds. And now I'm painting a picture of a domino impact, right? That means I've got patients taking up ER bays waiting for those beds. So instead of having 55 ED beds open, I might only have 20 because I need to get 30 patients who need inpatient care into our hospital, but we're waiting to get that bolus of people who don't need to be here anymore out.
Right.
That's the picture. Reasons for are numerous. If you want me to get into it now, I can. Be happy to. Workforce. It's not only hospitals where you hear hospital workers leaving the community during COVID. It happened to the skilled nursing facilities too. It happened to the acute rehab facilities. COVID. Even though you and I know COVID is less of a concern for morbidity and mortality, there's still requirements and regulations on isolation in a skilled nursing facility. So a skilled nursing facility typically has 2 patients rooming in a room. But if they're getting over COVID, they're isolated with 1. That cuts their ability in half. So long story short, there's a lot that needs to take care of in healthcare in our counties. So what can we do? Are we just going to wait and see who's going to take care of this and twiddle our thumbs? No. Our goal is, at least for our hospital, we want to be one of the first ones who have actually solved throughput from the ED out the door. If I can't rely on certain SNFs, acute rehabs, or ambulance transport companies to be more robust and take care of these, we're doing it ourselves. We've announced that we'll be opening up a 42 bed transitional care unit. We can put those patients then in a transitional care unit. A layman's terms for a transitional care unit is a place to put a skilled nursing facility patient for a week or 2. It's like a transitional skilled nursing facility until their permanent skilled nursing facility is available. That frees up those beds. That frees up the patients in the ED to get those beds. Then those individuals who are waiting in the lobby 3 to 4 hours or more during high peaks can get in faster. Not too many places will have that type of solution. Secondly, I mentioned durable medical equipment. Today, Yvette, if you had a loved one going home that required oxygen concentrators, perhaps a wheelchair, perhaps a recliner or a specialized bed, it could be 1 to 2 days for a durable medical equipment company to outfit your home. We're going to be a stockyard at San Antonio, meaning you don't have to wait 1, 2, 3 days. We'll have that to outfit your home. You're going home the same day.
Wow.
And by the way, the last one, the closer, is if a non-emergency ambulance transport rig, it looks like an ambulance, but it's for non-emergencies, and there's a dearth of them in San Bernardino and Riverside County, is unavailable, and they say they can't pick up your mom or your dad until tomorrow evening or the evening before. We're buying our own 2 rigs. We're going to be sending people home instead of waiting for a day or 2 for a commercial company to do it. So we said the Center of Aging was a one-stop shop. Our hospital is becoming that as well. And it's only going to make the community better.
I love it. All of these efforts and work to not only address, but in many ways solve a lot of these problems Thank you so much for sharing that. We're coming up on a break. So for everyone listening, I'm Yvette Walker with ABC News and Talk Southern California Business Report with John Chapman, President and CEO of San Antonio Regional Hospital, as he shares an update on the state of the hospital, as well as insight into prominent challenges and plans to address and tackle existing and future healthcare needs when we return.
Every 2 seconds, someone needs a blood transfusion. Be on the giving side. Livestream Blood Bank supports patients in 80 Southern California hospitals. Call 1-800-TRY-GIVING for more information and to set an appointment.
The University of La Verne is rated first in California for alumni satisfaction. Learn more about accelerated programs offered online and on campus in La Verne, Irvine, Ontario, Burbank, or College of the Canyons. Visit go.laverne.edu. The University of La Verne. go.laverne.edu.
City of Hope is driven to making a difference in the lives of people with cancer and diabetes. We accomplish this by conducting innovative research and providing outstanding care. If you or a loved one has received a cancer diagnosis, go to cityofhope.org to learn more about how our innovative approach could change your outcome.
Ontario International Airport is onto a better way to fly with over 65 daily non-stop flights to more than 20 major destinations and the easiest airport experience in Southern California. Visit flyonto.com/Ontario to learn more about Ontario International Airport today.
Hi, I'm San Bernardino County Sheriff Shannon Dykes. If you're looking to start an exciting career in law enforcement and make a difference in your community, we are hiring dispatchers, nurses, deputies, laterals, and many more. For a complete list of our jobs and more information, visit sheriffsjobs.com.
Hi, Ray Lance from the Diamond Center in the Claremont Village here. One of the coolest parts of a third-generation family business is getting to know the families we serve through generations. Once you experience our friendly service, our fair and transparent pricing, and our beautiful jewelry that we make to last a lifetime, you'll stick with us too. Come visit us in the Claremont Village or at Lantz, L-A-N-T-Z, diamondcenter.com and see what makes us different.
Cal State San Bernardino is home to the only school of entrepreneurship in California. With globally ranked degree programs, you can start your journey today to become a successful entrepreneur. Learn more and connect at entre.csusb.edu.
Welcome back. Yvette Walker here with ABC News and Talk Southern California Business Report with John Chapman, President and CEO of San Antonio Regional Hospital, as he shares an update on the state of the hospital as well as insight into prominent challenges and plans to address and tackle existing and future healthcare needs. Thank you again for being with us, Mr. Chapman.
Thanks, Yvette.
Beautiful. So as you know, you illustrated prior to the break all of the things that San Antonio Regional Hospital is working towards to address some of the more looming challenges. And because of the fact that you are independent, you can be nimble, you can pivot, you can adjust as you see necessary and whatever makes sense with the analytics that you're looking at, both to serve your patients and obviously be efficient across the board. Continuum of care is something that we hear a lot about. And I feel like that plays into the bigger scheme of things. Please talk about what that means and why we should pay attention to that.
Sure. Continuum of care actually came about from Medicare and Medi-Cal and CMS and payment methodologies, but it also refers to someone's clinical episode. So let me kind of paint that picture too. A continuum of care is from primary care, where you're hopefully they're trying to keep you well, to when you do get sick and you need acute care, that's the hospital, right? to the back end where now you have to potentially go through rehab, meaning skilled nursing facility, acute rehab. And then the end game is you're back to normal, right? So that continuum of care is from proactive care to episodic care to rehabilitation. And the reason payers bring it up is because if you really want to make a difference in terms of patient outcomes and quality, you want to incentivize healthcare to take care of the patient from beginning to end. Don't have it where they're seeing 7 different health systems not sharing information about you, Yvette, from your long-term issues, that from primary care to perhaps, God forbid, something happened, you had to end up in the hospital. So, and it's also going to become a way of payment by 2030. 2030, CMS came out with something called value-based care. All value-based care means is, can I keep costs low for that continuum of care, taking you from primary care to post-acute care? That's something that we strategically are getting ready for and trying to implement aggressively because it makes a difference now. So, going back to the community health needs assessment. It's a 500-page report. Don't expect you to read it, but I'll give you the highlight. The biggest highlight is, guess what? We're short primary care providers. No kidding. In San Antonio, and I shouldn't say San Antonio, but San Bernardino and Riverside, there's over 200 primary care physicians needed for our patient population, our county's patient population. So where do they go instead if you don't have a PCP? Emergency rooms, urgent cares, or worst of all, nowhere. Mm. And then when they do need care, they're in bad shape. So we, as I think some other institutions are doing, we started our own medical group, and our goal is to seed in the next 3 to 4 years up to 12 different primary care sites throughout San Bernardino and our Inland Empire. We started with one here next to the hospital that we can talk about because it's a special one. It's about readmissions. And our second one's going to be opening in Fontana, another area of need. We just put up urgent care in Ontario, an area of need. So our goal is to take care of that front end. We have the episodic, we have a fantastic hospital. And I mentioned that TCU and DME stockyard and our own transportation company on the back end. So we're setting ourselves up to be that continuum of care for this community.
Absolutely. And a complete healthcare system in itself, not, just a hospital, but a complete healthcare system for every stage of life, it sounds like.
Right. Or if you can't be an end all to everything, you have partnerships. And that's behavioral health, right? One of the things that I described is great for non-behavioral, organic clinical care, but where are we seeing the most need, especially after COVID? And we're hopelessly failing nationwide is behavioral care. One of the small things we're doing specific for our San Antonio community is those same primary care sites that I've been mentioning. We're going to have a behavioral health specialist in them as well. So when you see your primary care, you need to see someone for anxiety or depression, you'll be able to see them in our primary care site. I really do believe if you read American Hospital Association and others, that's really what's being recommended. The hard part is to get the payers to follow along and cover those costs. But with the type of expenses they're seeing nowadays, with the comorbidities of psychiatric disorders, they're coming along.
Right. Well, it makes sense. And like you said, the data is very clear on what the best path forward is. And it sounds like you're following the data and creating those solutions as you go, which is exactly what we need to be able to meet the needs for today. And you mentioned that, a San Antonio Regional Hospital could really use 200 physicians, and looking at, workforce development. So not only physicians, but staff and others that basically make the hospital function. What is it that San Antonio Regional Hospital is doing to develop or to grow the workforce in that area?
You're setting me up. Thank you. It's perfect. It's a good setup. I'm sure all of your listeners have read with people retiring, getting out of healthcare, the stresses caused by COVID. It's been a battlefield, no kidding.
Right.
I think what I read in Becker's Healthcare is the average turnover in terms of percentage in just hospitals, not alone physician offices, approached over 30% over 2 years in healthcare. That's 1/3 of your workforce leaving. Where are you getting that? You're not. So if you really want to survive, you want to benefit your community, I would like to think the intelligent ones are setting up workforce pipelines. So for example, at San Antonio, we have contracted with 3 nursing schools, and we take over 120 new nurse grads, train them for 3 to 6 months, and offer them jobs even before they start training. So the idea is to resupply the clinical nursing workforce. But that's not it, right? That's not all of it. Nursing's a huge component, but you're looking for even people who are infection control, your EVS workers, your what I call the introductory hospital type of jobs, where you have registration, you have patient access, patient care navigators, medical assistants, nursing assistants. They're all needed. Well, isn't it a win-win if we reach out to the youth in our community, let them know about these careers and help them get there, meaning help pay for their education, get them interested in that education, and then keep them here in our community working for San Antonio? So our goal, part of our strategic plan that our Board of Trustees has approved, is to develop over 6 non-nursing pipelines this year. Wow. I mentioned to you, Yvette, before I came on, I was meeting with the Upland High School District on just how we can do that, partnering with them, Chafee, and us to create nursing assistant and phlebotomy programs this year. Dealing with Dr. Lieberman at Laverne for OR technicians, lab technicians, and other what I'll call non-RN type of pipelines. So we're really excited. We're even reaching out to the high schools whose the kids may say, I'm tired. I'm not ready to go on to further education. Well, guess what? You come here, you can join and become a EVS technician and help with housekeeping versus registration. Be that person who talks to the patient and gets their insurance and demographics. And then after 1 year, I'll put you for 30 days in any other department that you may be interested in that might take 6 months to a year certification. I'll invest in you. I'll get you that certification, and you just become my new OR technician. We're well on our way of doing that.
That is amazing. That is absolutely remarkable. Not only to have the foresight to partner with these amazing stakeholders to create those additional pipelines. You said 6 additional pipelines in addition to nursing. Right. What will those 6 complete pipelines look like?
Exactly. Kind of what I described. So if I use Chafee or Laverne, they'll be sending me, they'll be creating programs specific for hospitals, or if they already have it, augmenting, meaning adding more students. And we're signing an agreement saying we're taking those students on. We will be training and hiring them for their practical, and after they get certification, we'll be placing them in jobs. that makes the our educators' eyes light up, because who wouldn't want to tell their student, you join this program, you're guaranteed a job.
Right, absolutely. And especially when you have the CEO and the president saying, I will invest in you, right? Just as somebody invested in you when you were looking to grow and move on in your career. And today, more than ever, it's so necessary with, as you mentioned, the staff and the physicians that dropped off during COVID, the growing need of the aging population. It seems like from every front, the need is only going to increase. And these positions are very well paid, fulfilling positions, wouldn't
Yeah,
you
let me
say?
give you an example. Phlebotomy. Coming out of high school, you can get a 3-month certification. You have to do a certain number of draws. For those of you who don't know what phlebotomy is, it's blood drawing. How would you like to be a high school student? Your first job is paying you $23 an hour. Not bad.
Not bad at all.
Right. You do it for a year and a half, and then we start investing you in careers that pay up to $45 to $50 an hour. And we keep the talent, the youth in our community here, and not looking for jobs elsewhere and leaving our community.
Right. Right. And it's part of that whole brain remain philosophy that I know Dr. Lieberman has been working so hard to combat in our region, because really we have so many brilliant minds, just amazing intellectual gold mines right here that we really need to keep. And, in addition to being well paid, they're also always going to be needed, right? There's always going to be someone that needs to have their blood drawn. Hospitals are always going to need, phlebotomists or any type of staff really to keep up with the demand of the healthcare system and the growing population of people that require, healthcare.
Right.
So
And
that's
Yvette, you're a mom. It would be like, how do your kids know about what's available out there for healthcare? They probably don't, unless there is a definitely dedicated and thought out process of exposing kids, even in grammar school and high school, to healthcare fields. This summer will be the first hospital in this region starting a clinical shadowing program where we take high school students all summer. One high school student, 2 high school students watches and partners with a cardiovascular surgeon seeing over 150 heart surgeries. How many high school students have that ability? None. These days, it's join the volunteers. Hey, you could serve in the gift shop, wheel patients around. We want our students to see what the career is really like, whether that be shadowing someone in primary care who's seeing their patients, to the other extreme I just said, watching open heart surgeries. So we're taking up to 24 high school kids this summer. That's what they'll be doing. We really want to market and expose them to the variety of different careers in healthcare.
Absolutely. And so I recently had the privilege of serving for student panelists for the County of San Bernardino, led by Ted Alejandre, Superintendent of Schools for the county. And the common theme that each of the presenting students, I think I heard 2 or 3 presenting groups, indicate that they want to have career technical education brought back to their schools, so that, there is a pipeline for those that maybe don't want to go directly into a 4-year university, but want to get more of that technical training and ability to get their foot into a solid career where they can grow and flourish. So thank you so much for everything that you're doing. Another thing that we hear a lot about recently is health equity and inclusion. Please talk a little bit about some efforts that San Antonio Regional Hospital is taking on to support those efforts.
Yeah, I touched somewhat on an example when we spoke about factors that made the Latinx community more prone to having higher morbidity or mortality with COVID. And with aging, you're more prone for falls, you're more prone for fractures and breaks, you're more prone for urologic types of issues and orthopedic type of issues. that's actually considered unequitable too. So that's why when you think of, it's not just ethnicity and race, it could be age. So in this case, Center of Aging is a second way we're dealing with a group that needs to be focused on. A third that I'm sure you've heard, and probably many of your listeners, even the African American community, they tend to have a higher aggressive, higher frequency form of prostate cancer. So we've actually doubled up the number of population health staff we have who are going to be canvassing not only the city events, but also going to neighborhoods, churches, any like local events. And by zip code, based on this community health needs assessment, says that, this zip code has a higher African American community. We're going to offer free prostate-specific antigen testing to capture those who may not know that they may have prostate cancer. So that's a third example of going out into a community and what I'll call targeting specific modalities for disease-specific modalities based on inequities.
Right. And as
Does
we
that
know,
make sense?
yes. So as we know, when it comes to identifying cancer and, screening for that, time is of the essence. So being proactive, going out there, serving the community and getting, everybody the healthcare resources that they need to stay healthy is amazing. So again, something to be very proud of as a leader of San Antonio Regional Hospital.
Let me give you one last example, not to beat a dead horse, but I really like this example. For patients who are lower on the income scale, maybe they have Medi-Cal, maybe they don't have insurance, they tend to be more at risk for readmissions, meaning if they've come to a hospital, when they leave, first of all, do they understand the discharge orders? 2, do they have the funds and the transportation to make sure they get their medications? 3, do they understand what they're supposed to do with their medications? And 4, are they seeing follow-up within 7 days? The answer I already know. Right now in the state of California, that type of population typically comes back for an acute care stay, a readmission within 30 days. 38% of them. 38% of that population I just described is back in the hospital, especially, excuse me, if it's congestive heart failure, pneumonia, or uncontrolled diabetes. So I mentioned the first primary care site is called a readmissions clinic. Any patient who leaves our hospital with any of those 3 conditions, we automatically give them an appointment before they leave, before they're discharged. We say, hey, here's your appointment. You're coming back. It's right next door. Do all of them come back? No. We've been pretty good. About half of them do. You want to guess what their 30-day readmission rate fell to? From 38% to 12%.
Just with that adjustment, that minor adjustment.
Just by them seeing a physician within 7 days where they walk through exactly what they're supposed to do with their medications, making sure they got their medications. Oh, and by the way, Yvette, we're opening up a discharge pharmacy in the next 6 months. So every inpatient who leaves gets not 1 day worth of medication. They get a 30 days worth of the medications they need. So they have time to get to a commercial pharmacy if transportation is an issue.
Right.
So we're really excited about the providing discharge medications to our patients who are being discharged from the hospital and having a clinic that can see them within 7 days of discharge.
So you truly are becoming a one-stop shop or one-stop center for complete healthcare, from having your appointments made to being given your prescriptions. Because I don't know about you, but if you leave the hospital, you probably are in the hospital for some reason that you may not be in the condition to go out and get your prescriptions, right? So letting your patients leave with the 30 days supply of prescriptions, that's remarkable. In addition to making that appointment and walking through everything with your patients, that in itself has already shown more than half of those patients not having to return, which is, I can only imagine what the final outcome will be when you do implement, the pharmacy and you have everything on board. It's very exciting. And I know that we were talking a little bit about the Hospital Association of Southern California and their recent address to plan to address behavioral health care. And you covered that so beautifully. So during your time at San Antonio Regional Hospital, the hospital has been recognized as a top 50 hospital in the U.S. for cardiac surgery, has received Women's Choice Award for stroke, orthopedics, heart, and cancer, as well as received the Blue Distinction Center Plus Award for maternity. What do you attribute this momentum and caliber of healthcare to, Mr. Chapman?
I consider that due to the employees that we have working here and the enthusiasm they have of knowing that we're making a difference in the community. When they hear about these same programs that are coming in place, they're excited. They're saying we are making a difference. And when you get that ball rolling the right direction, those employees are bought in, and the care is even better than it usually is. So. It's
Beautiful.
definitely a testament to our providers and our staff.
Quickly, Mr. Chapman, what do you look forward to in the future with the hospital?
What I look forward to is the next community health needs assessment over the next several years that continually shows our community getting healthier, 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 and healthier, or is in a top 20 community in the U.S. for healthcare.
Beautiful. Thank you so much for sharing this critical information and very inspiring outlook for our healthcare system. Thank you again, Mr. Chapman.
Thanks for inviting me, Yvette.
Beautiful. For everybody listening, these are some events coming up. The Southern California Air Show at March Air Reserve Base in Riverside, California, taking place April 22nd and 23. Admission and parking are free. Save the date. Women of Hope's 4th annual Beauty Bubbles and Bites is scheduled for Thursday, June 8th at the beautiful Pond Oaks venue in Mount Baldy. To get your tickets or become a sponsor, visit www.hthf.org, Beauty Bubbles Bites, or contact Daisy Macias at 909-509-2094. Don't miss my interview with Jane Epstein, a survivor of and advocate for survivors of sibling sexual abuse and trauma. Today, Jane, co-founder of FiveWaves.org, is an international 501c3 advocacy group that offers information, support, and guidance about sibling sexual abuse and trauma at siblingsexualtrauma.com. Next week, we will have Travis Park, owner and president of California Recyclers, an innovative and superior quality recycling center that is top ranked in the industry. Travis's entrepreneurial spirit has moved him to branch out into new industries, including converting plastic waste into diesel fuel. You do not want to miss it. We will see you next week, everyone.